Hey Stubby Nails Club. Persistent pelvic pain and persistent low back pain can be one of the trickiest things for us to assess and treat. So today we'll be talking about our top 3 differential diagnoses that you do not want to miss when you're assessing pelvic pain, because that could really prolong someone's suffering. And as we all know, the root cause or causes of a persistent pelvic pain might not be in the pelvis at all. So don't forget about these 3 things. Okay, let's get into it. Number 1, do not forget to assess your neuro scan. And why might that be? So a lot of the time, especially if you're working with a younger crowd, aged between late teens, early 20s to 30s, this age group is susceptible to more disc injuries, for example. I always like to say that the discs are kind of nice and juicy during this time. So this is when you might see those disc issues come up, especially in the crowd that does a lot of flexion, a lot of deadlifting, a lot of squatting with improper form, or just not being careful with their hip mobility and going for those heavy weights anyways. So guys, don't forget to do your lower extremity neuro scan. I know that you know how to perform a neuro scan for the lower extremity, so I won't be going into detail with that, but please do not forget to test your neuro scan. Take those 5 minutes and you might be surprised what you find. If you find one level that's impacted, you might consider that might be disc. However, if you notice that all the levels are impacted from L1 all the way down to S1 on, let's say, the right side, then you may want to consider the hip flexors, which brings us to our second point. Number 2. This is less of a diagnosis and more of a pattern recognition, and we as physios know it as lower cross syndrome. So this is a common muscular imbalance that involves really tense hip flexors, low back extensors, paired with weak glutes and a weak lower abdominal. So a lot of this can create a general presentation, and if you guys can picture that crisscross diagram that's shown in every textbook, every PT textbook, then you guys know what I'm talking about, where the mechanics of someone in that APT kind of presentation, anterior pelvic tilt, can generate issues for pelvic floor dysfunction, right? This is not an optimal position for us to engage. I want you guys to try engaging your pelvic floor in that lower cross syndrome presentation, so that increased lordosis, APT. Try to engage your pelvic floor, and now try with a stacked rib cage and pelvis. Way easier, right? And so with that in mind, this is where we might want to educate our clients on how to lengthen the hip flexors, how to lengthen the back extensors, the QLs, and then educate on how to strengthen and activate the glutes, because they may not have realized that their back's been overdoing the work and the glute med has not even been firing this whole time, because it's super difficult to fire your glutes when you're in that pattern. And so a lot of body awareness training, cueing, hip flexor stretches, core activation, getting to know the pelvic floor involvement in all of this, and the close connection between hip flexor and pelvic floor, as well as glute strengthening, can really do wonders for this group. So yes, do not forget to observe their pelvis. Do not forget to ask what kind of occupation they have, how they hold baby, their patterns in their body, and recognize that if one side is lighting up all dermatomes, all myotomes, you may want to consider maybe a lower cross on one side of the body. That I see more common than you'd think. So again, going back to it, don't forget your neuro scan again, right? So it can tell you more than one thing. Okay, number 3. Guys, please don't forget to assess for any scar tissue adhesions and myofascial restrictions. And this one is so oftentimes missed and is such an easy, relatively easy treatment path. So how would you assess? Number 1 is in the subjective interview, asking if they may have had any childhood trauma, sexual trauma, some scar tissue, surgeries, abdominal surgeries. It could honestly be any type of surgery, maybe not dental, but I'm talking about abdominal, I'm talking about breast augmentation, tummy tucks, C-section, of course, scars from perineal tearing. Those are some of the more common ones we see. But it really could be any scar tissue anywhere in the body. And there's times where I've treated scar tissue from an old injury, from the shoulder, old injury from the knee, and that's been seen as an improvement with either pain at the pelvic floor or dysfunction at the pelvic floor. So guys, do not miss your scar tissue adhesion assessment and treatment, especially when you're finding all the objective findings together. It's just not making that much sense, right? It's not a biomechanical source. It's not looking like a strain where, you outstretch something, hurts, and then you utilize the contractility of that tissue, also hurts. It's just not a biomechanical pattern. When you find that your findings are all over the place, that's when I actually start moving more towards myofascial or visceral fascial or scar tissue type treatments. So do not forget to ask about any type of surgery, not just the birth injury. And then also just have a look, because remember, you can have myofascial adhesions without a single surgery. So you guys do need to assess, even if there's no trauma, no surgery, no incision, no injuries, no nothing. Go in there and check for myofascial adhesions with skin rolling. Maybe you have visceral fascial knowledge. Go check the fascia and see how mobile it is, right? This one is so key. If you guys want to learn more about visceral fascial mobilizations, I strongly encourage you to check out Ramona Horton's courses on visceral fascial mobs of the urinary system, the GI system, and the reproductive system. Super great courses. Cannot recommend those courses enough. Okay.